Conference, Common Good at Stanford University, and to session track 2A. We're in Berg Hall C, and the title of this session is Evidence-Based Algorithms Across the Spectrum of Care. I am Michelle Williams, Senior Clinical Advisor with Health Technology Forum, and it is my pleasure to introduce Dr. Rhonda Montgomery to you. Dr. Montgomery is an internationally known scholar in aging who was the first person to hold the Helen Bader Endowed Chair in Applied Gerontology at the University of Wisconsin-Milwaukee, where she is an emeritus professor in the School of Social Welfare and in the Department of Sociology. Dr. Montgomery received her PhD in sociology from the University of Minnesota. She has published over 100 articles and books, including a chapter on assessment of family caregivers in the 2018 Handbook of Geriatrics. She's received numerous awards, including the 2010 Rosalind Carter Institute Award for Leadership in Caregiving and American Society on Aging's 2016 Gloria Kavanaugh Award for Excellence in Education and Training. During her tenure at the University of Wisconsin-Milwaukee, Dr. Montgomery successfully developed an applied research program that is now changing the manner that community and health programs work with families to care for older adults and for wounded warriors. With community partners, her team developed and tested the Tailored Caregiver Assessment and Referral, TCARE, protocol. TCARE gives professionals a means to assess and support family caregivers who provide care for older adults with dementia or other chronic conditions. In partnership with the University of Wisconsin-Milwaukee Research Foundation, Dr. Montgomery launched Tailored Care Enterprises, LLC in 2012 as a startup company to bring TCARE to healthcare systems, insurance programs, and employee benefit programs. The company was reorganized into Tailored Care Enterprises in 2014. The TCARE program is now used by over 250 organizations in 17 states and has recently been included as a Medicaid benefit in the state of Washington. Please join me in welcoming Dr. Rhonda Montgomery to the podium.
Thank you, Michelle. That's probably more information than we do in insurance. Appreciate that. I was just sharing with the folks down here that we kind of just rebranded ourselves TCARE again because we found out we had a presence in people around the country as TCARE, so we decided to go back to that. Let's see, give me here. So, here's what I'd like to do today. We're going to just set a small agenda and leave you plenty of time for asking. I want to talk about what the problem is that we set out to do. I need to talk about identity discrepancy because it's so core to what we're doing. And then I'll talk about the TCARE solution, but woven in that is how the algorithms do it. I love the presentation this morning because from my belief, we're doing exactly what somebody advocated. We're making services, or we're making the help accessible, we're making it translatable, and therefore making it usable, and action. It creates action on the part of caregivers. So that's kind of where our algorithms are honed. And then I'm going to talk about some of the outcomes that have come from this and how those algorithms feed into it. There's 65 million family caregivers today around the country. 1 in 5 adults is a caregiver. If you listen to Rosalind Carter, she's going to tell you, you either are a caregiver, you've been a caregiver, or you will be a caregiver. That's how it's going to go in this country. 80% of long-term care is provided by family members. And I hate to tell you, but that number hasn't changed over the 30 years I've been in this field. 80% of care is provided by families. And the most recent estimate is that that's worth $470 billion annually, which is a lot more than we get put in from other sources. Now I want to kind of talk about the problem and why we started this and where the algorithms came from. Family caregivers have higher rates of most of the chronic diseases, the basic chronic diseases. They also have increased behavioral or risk factors and sort of an unwillingness to take care of themselves because they're so busy taking care of others. And of course that all translates to dollars. Dollars for healthcare systems, dollars for the private payer, dollars for the payer systems. All those costs pay for the fact that the presence of a family caregiver improves the compliance with medical regimens, as well as medications. It shortens hospital stays, it reduces readmissions, it prevents unnecessary doctor and ER visits, and it prevents or delays nursing home placement. And overall, if you ask most people, both the family member and the person cared for, what most people want to do is be cared for at home. So with all those benefits and yet all those costs, the question becomes is why haven't we done something systematically? And that's because I believe the healthcare system is running on a flat tire. What's happening on the right side of this flat tire here is what's normally out there. You have a care manager who's communicating with the patient, communicating with the payers, that's communicating with the providers. But there's no place in that model for the family caregiver who's doing 80% of the work and probably making most of the decisions that we pretend are patient-centered decisions. And there's no place in that original model that really brings in all of the social services, many of which are low cost or free, that can actually help that system operate more efficiently and actually more effectively. So the problem is caregivers quit when they burn out. And when they burn out, if you reverse everything I just told you, it means that it lowers the quality of care, it increases the use of long-term care services, it increases the use of hospitals. And so the question becomes, the real problem is, why do caregivers quit? Because that's what we want to fix. Well, I'm going to tell you what the answer isn't, but what most systems have been built to address. Despite what everybody thinks, the ADLs, the IADLs, the functional levels of the care recipient have zero relationship to whether or not that family member is intending to place them. I can't tell you how many times I've presented this to systems that are just in shock. I have data from thousands of caregivers, and this is what it looks like. Zero correlation. It also has zero correlation to the hours of care or the type of care that caregivers are doing. And yet most programs are built to address those two issues, which aren't the problem. The problem is related to the emotional part of caregivers. And I've got up here, we have a measure that we call identity discrepancy, and I'm going to go into that in a minute because it's so core to what we're doing. But in my view, it is the barometer. This is one of the measures that we developed. When identity discrepancy goes up, then we see multiple types of stress or burden. Types in terms of feeling overloaded, relationship between the caregiver and the care recipient, which is huge. That stress burden from worrying about what's going to happen next and can I afford it. We also taps into what we call uplifts. We actually measure, because it's ironic, caregivers can be depressed and they can have all those stress measures and they will still tell you that they really feel good about what they're doing because they feel like they fulfilled some role. They actually have uplifts out of it. And when we're developing plans to help them, it's very critical to understand those because we want to play on those. And then it's highly related to depression. And all of these measures, it's showing here, are related statistically significantly to intention to place. So what we discovered through years of research are two very simple facts. It's amazing that you have to do so many studies to see the obvious. The obvious is, first of all, it's not a one-shot thing. Caregivers are on a journey. When I first started down this, I used to talk about a career. But caregivers used to say, I don't want a career in caregiving. And most caregivers cannot be identified initially if you try to advertise to them, because they are a husband, a wife, a daughter, a son, so they don't even know you're talking to them. So what we did, I'm going to talk to you about what identity discrepancy is. First, through our research, we have mapped 5 phases of caregiving. I know there's only 4 showing here, but I'll tell you about it. And this is how it goes. You have some familial relationship. Nobody wakes up and says, I want to be a caregiver. That isn't what happens. What happens is you have that wife or that daughter, a little less often, but sons, who are being that wife, daughter, or son. And if you think of these pie charts, think about how in every relationship we have, we carry sort of a rule book in our head about how we're supposed to behave in that relationship. And that rule book, there isn't any standard rule book. It's your rule book. It's influenced by your culture, your gender, your situation, but you still have a rule book. I often call it my mother's voice in that tape recorder in my head, telling me how I have to behave. And we operate from that. In the first phase of caregiving, you see that little sliver of the pie, that the caregiver kind of takes on some understanding that they're stretching a little bit beyond what is that original role. Most often we do not see them in systems. They don't identify, they don't even see themselves as that person. The second phase looks more like the quarter up there, where about a quarter of it is, and that usually comes what I call the aha moment. And remember, there's no calendar time on this. It depends on that relationship and the disability and how quickly that disability is moving. But there is an aha moment. At some point you think, wow, I'm doing these other things and that isn't what I used to do. I'm here to tell you I've been a 3-time caregiver, and each experience has been different. I started with my mother-in-law. I cared for my mother, and I am good and bad 4 years into the journey of caring for my husband with end-stage cancer. The good part is he was given 2 years, so we're still there. And I believe that part of it is how to support the caregiver, to support that patient, so we keep the depression out of the house. So what happens is you get that aha moment. And the first time I got that aha moment, I spent my time driving to the office, because I really don't like phone time after work, so I was taking care of the discussion with my sister-in-law for my mother-in-law, the discussion with my sister for my mother. And I realized I got into work, and all I had done was attend to the needs of these 2 women. I went, I'm a caregiver. And that was long after I kind of did this. I did this on studying data for thousands of caregivers, and then I realized that's where I was. Then what happens in the third phase, where you get to the 50-50, is usually it's some kind of task that's uncomfortable. It's not hard to do, but it's very uncomfortable. The most obvious is, this is when sons bow out often. They don't have long in this phase, okay? Because when mom needs a bath, that is really uncomfortable. Sons don't do baths. Or as my son will say, I don't do emotions, call Susie. Okay, there's certain things that sons don't do, but everybody has it. For spouses, it goes a little further. It might be toileting or something else, but something triggers this, and they realize half of what I'm doing is all about being a caregiver. And as you do that, you're letting go of part of that other role. The fourth phase comes, this is the point that sometimes people actually need to let go and go into another place setting. And it usually comes at this point. And here's the comment I most often hear. You know, she's not really mother anymore. Or it's not really my husband anymore. Because the role and that relationship is totally dominated by that caregiver relationship, with very little left of that familial relationship. And the fifth phase is not showing, actually looks like the second phase. That's when a caregiver makes that decision to let go. The fourth phase, I say, starts the first time a caregiver thinks about placement out of the home. And I say the first time because that decision is visited and revisited before it's made. When it is made, then they can regain to some extent that initial relationship, but they never give up. Anybody that's worked in a nursing home or any kind of setting, you know that that caregiver is always there. Now, what's important about this model isn't so much what takes place within each phase. It's what takes place between phases. That is what I'm going to talk about, is identity discrepancy. Because what happens is this isn't a smooth process. In our data, the belief that the more you did and the longer you did it, then we should see that related to depression and stress and intention to place in a linear pattern. Never found it in the data. What we found was linear, down, linear, down, linear, down. If they made the leap to the next phase, then things could get better. And what happens is people get close to sitting on that fence and they're thinking of their relationship, as we're seeing on the green side there, like 50-50 in this case, and their rule book is telling them to operate that way. But because caregivers do what needs to be done, they're actually doing tasks and taking on responsibilities that look like the right side. So they have what I call identity discrepancy. And I'm going to put this down because I have my one and only prop here, and it's the most telling thing that tells me what to do. This is our T-Care rubber band. This is how I'm thinking I should be acting in this relationship. And this is how I'm acting. The further my actions stretch from what I'm thinking, the tighter that tension. That is identity discrepancy. And we have learned that that drives depression, it drives letting go, it drives stress, and so our model has to figure out how to fix that. And it's obvious. You either change the way they're thinking, or you change the responsibilities they're taking on. And to be safe for the caregiver, this is the family caregiver, and for the family member, we have to know which direction to go. Or are we just trying to tweak it so they kind of both line up and we're not going to let them go past that phase, we're just going to help them. So that's the core idea. Simple. But it makes all the difference in the world. Oops, there we go. So what I say, it's not what they're doing. It's what they're doing relative to what they think they should be doing. Therefore, in my many interviews and visits with family caregivers, I began to understand why one caregiver could be doing everything, and I looked at them thinking, like, why aren't you falling apart? And the next one barely got their toe in the water, and they're calling saying, I want to put mom in the nursing home. That's the answer right there. It's not what they're doing. It's relative to what they think they should be doing at that time. And as I said, identity discrepancy leads to the various burdens and depression and poor health. So I'm going to quickly go what the model is, and then I'm going to come back and show how the algorithms are driving this model. And the easiest way to share this model in terms of how it operates we have a SaaS system that does this, is I'm going to share the story of my in-laws. Okay. My in-laws, I think that's why my husband's still with us. They lived well into their 90s. They have great genes. And so I had an 87-year-old mother-in-law taking care of a 92-year-old father-in-law who had macular degeneration and dementia. And what happened, and this is what would happen, if the system we've set up is it would be a care manager, care coordinator. In their case, it was me, okay? And we do the assessment, which assesses those key dimensions plus the context. Something else I heard this morning. We need to understand the context within which it's doing. So we do, but it's very efficient and very effective. And one of the most effective things it does is it brings people to say things, not just to answer our questions, but they volunteer information. I've repeatedly had care coordinators say to me, I've worked with that person for 2 years and I never knew. There's all these hidden things going on in their life. What that assessment does is then our algorithms take those key measures plus a few more things and devise a plan that is tailored to that caregiver at that point in their journey, with the understanding it's going to change in the next 3 months or so as the patient's condition changes. In the case of my mother-in-law, the trigger for her was she could no longer bathe him, but she wasn't going to give up. But that was too much, and so she's thinking, I have to place. And the other thing that was bothering her is she lived in a continuing care community, and he embarrassed her. Their friends, they go to lunch or dinner, and he would behave in ways and ask questions that were embarrassing me. And I can remember her asking me, why does he do that? And I started explaining Alzheimer's disease. In her case, this system would have identified not only the general type of service, but it would have told her exactly where to go get it, how much it costs, what were the hours, because caregivers don't have time or energy. I'm amazed at all the websites for caregivers. They're useless. When you're overwhelmed, you have no idea. Most caregivers will come and say, either I need respite or I need a lady. They don't know what that lady's going to do, and they don't know what that respite's going to do. And what that means is our systems, our state systems many times, then have these huge waiting lists for a service that they won't even use when they get there. Because there's no way in this broken flat tire system have we addressed the needs of the caregiver to keep them from burning out so that they have all these positive impacts on the patient. So for my mother-in-law, the real thing that came out was both the identity discrepancy, I'm not supposed to bathe my husband, and the relationship burden. The plan, never more than 3 things, too many choices. We can get a lady to come in a couple times a week to bathe him. We can get you to a class so you can learn about Alzheimer's disease and behaviors and how to deal with them. And the third one was we can do an adult daycare center. We consult, we explain what all the measures mean because we have norm data, psychometrically sound norm data, so we know is this person on the high end, the low end, it's a thermometer that works no matter what gender, what race, it's the same thermometer. We know that. And so in her case, she didn't want to do adult daycare. Well, pretty soon, Grandpa was telling everybody in the building what a great bath Mary gave him. And my mother-in-law was so embarrassed by that what we did was then adjust. We were still trying to deal with the same issue, the relationship, keep it going. Seeing the impact on the STARS CMS programs. So that was a new little market fit for us. The path for Washington was they figured out exactly summarizing what we're saying. Someone has a need for care, family caregivers become exhausted, out-of-pocket spending exhausts resources, and they're on Medicaid. So one of the other things that Washington has done with their 1115 waiver is they actually have CMS paying for our product when the care recipient is physically eligible but not financially eligible, with the goal of prevention. And they figured out that in their plan they had 5 things, and 3 of them were about screening and assessment of the caregiver, consultation and planning for the caregiver, and using evidence-based interventions. So that's where we arrived at evidence-based, Medicaid approved, and lots of great testimonials from both the caregivers and the care managers. And my favorite story is the recording that was left on one of the care managers' recordings, and it said, "I've been at this for 5 years, and after I talked to you, it's the first time that I felt I was not alone and I was gonna sing and skip down the street." And that's the reaction we get from caregivers. So I'm gonna stop there. Thoughts? Questions? It's using algorithms and information and problem solving in a point in the healthcare system that it's actually been void. Healthcare systems have a class, they have a little, go here, they might say go out to the social services, but there is no navigator for them, and there is no navigator that hangs with them for the whole journey. And that's what these algorithms are designed to do, with a full understanding of what really is the pressure point for them.
So how far do the algorithms go in terms of specific advice? Because you had said it was actionable advices and not just go find a place, go find this place. And how do you get all that information?
Okay, so the algorithms, we have a model that includes 16 major categories with 99 specific categories, kind of generic categories of service types. And most of them don't say caregiver. In the military version, it's a little more because we add things like child care, things like, and of course dealing with PTSD. But, so we have those generics. What the model does is it steps down. It says, first of all, this is the most appropriate goal. Second of all, this is the most appropriate strategy to reach that goal. We actually have 4 strategies that are used. And sometimes you can have more than one, but it weights them, okay? And then it comes up with a fairly, what I call a little crib sheet that says, okay, nobody's gonna use all of that. So here's the crib sheet of the things that could be used, and we look for the twofers. The service that's likely to meet 2 of those strategies and reach it. Then we link into a scraped database that is regional. So you put in your zip, the care manager puts in the zip code, and you will come up with the specific services or resources that are available in that community. And that is what is brought to the caregiver, along with that original scoring sheet, so you can sit down and say, just like with blood work, here's the score, here's where you fit on that range, and that is why we're giving you this. The obvious reason caregivers don't use services, which I spent another 2 years studying, that's a question that was out there. Nobody uses something that you think costs too much or you don't see the value. And cost for them is not just money, it's time and energy. If I have to spend 3 hours getting them ready to go to adult K-care, it's not very useful for me. So understanding what has value to that caregiver at that point in time is what the algorithms really do. And they point there, and then we link to what's in that community. It also opens up the rural areas, because always I get kickback, but we don't have all these services here. Well, if you think about the strategy, like one of our strategies is to reduce the workload. So my example, I have 2 wonderful ones. There was one group in rural Georgia who put a student intern on and called every pharmacy and every grocery store and said, do you deliver? That is reducing the workload. You don't have to necessarily have a chore service. In Hawaii, I was out in Maui, and they didn't have a respite service. But through this program, they had identified as part of the context that this gentleman who had Alzheimer's had this really good buddy that he'd always gone fishing with, who had disappeared out of fear of the disease. Connected him once a week. He took that man out fishing for a half a day, and that was respite for the caregiver. It forces out of the box thinking, because you don't jump to the service, you jump to the goal, the strategy, and then align with the services. That was too long of an answer. Any other questions? Yeah.
A lot of the services you provided obviously are for family caregiving. Do you see any of the same issues apply to commercial, or I don't know how you categorize it, but I would imagine that people who are caregivers professionally would also have depression and burnout.
Yeah. One of our original partners and still an investor ran home health company.
Yeah.
And the reason I got connected with him is I was invited because based on our theoretical work, which is published places, he had used it for his dissertation to address his paid caregivers in his home health. And he found it very, very helpful. We have not taken that out that way, but it is certainly on our radar. Others? Quiet.
So how do you find all the services between Maui?
I was just gonna, so how do you find all the services, I mean, between Maui and rural Georgia and Washington State? I mean, there's a big difference between Seattle and Spokane and
Absolutely.
the Duluth area, so how do you?
Okay, so, most states have a 211 system. Most state programs have some kind of sometimes it's just a paper pencil book. Others have, most of them these days have some kind of a data source for just in the aging networks. And in the military, we actually went in and helped them create a database for the services that were on site. That was most interesting because we were operating in Washington, but we were also operating in Lewis McChord. And when they realized that, both sides were totally unaware of what was available on the other side. And so then they hooked up. So we go in and scrape those and then align them with our model of 99 categories, and then that comes in to the system when we have a generic, then it will pull up that database for that location, mostly based around zip code.
And then are you monetizing that in any way? The third parties that might provide?
We're a startup, that's the next thing, but no, we haven't been. This is a system that was built out of heart. I wanted to fix the wheel. I had no intention to start a business. That wasn't what I wanted to do. But by the time I was exiting the university, we had these people, like whole states and whole programs using it, and there was not going to be any support for the system that we had created. So I went to the Research Foundation, and that's why it rolled into a company. And then I went and found some key partners, one of whom was a woman who started as a graduate student, has been with the program ever since, has built it all the way through, and she's got a master's degree in social work, and she knows this stuff inside and out. And then I had to ultimately go find a CEO who could translate the business world to me, and he is doing that on rapid speed. And so that's where we're at.
Ultimately, to support you, you have to make money somehow.
Yes, and so the money is we charge for the license per care manager or per care coordinator. Our original people were very low cost. We're working with them to beef that up. But our target markets for growing, and we got a partnership going now with Minnesota Blue Cross, is the payer systems, who are really seeing the STARS model, and the employee benefit programs. We're in discussions with them as well, because I didn't talk about the hit of caregivers on absenteeism and presentism and healthcare for large companies is huge as well. So there is a benefit there. And what we have done since the beginning research, which was paper pencil, is of course all of this has been now put into a SaaS system. Yes?
Hi. Forgive me because I moved, I had to duck out for 5 minutes, so I hope I haven't not saying something that you've already covered. I'm in the aging and tech space. My company is developing a solution for people with dementia. So I'm very interested to know how you view the emerging digital transformation of services that ultimately, hopefully, will empower family caregivers to make good decisions and also to have access to digitally based activities and therapies and all sorts of, there's a massive excitement around digital therapeutics. How do you factor these emerging movements into the traditional care at home, care provider, assisted living model?
I think that the first thing is everybody wants to stay at home, and I think those digitals are key. And as we grow with what we're doing, those will become part of our services. I mean, this is better viewed as a triaging system than anything else. It is a triaging system getting people to where they need. So I don't see this in any way competitive with any of those other products out there. It's just, and actually they can be triaging and they can be business builders for others, which is kind of what you're talking about. That can be monetized. The other place it can be monetized that I didn't talk about is that I talked with folks from Optum, and there's interest there because as these models are being built out and they're taking psycho, geo, physical care, they're building all these models to get precision treatments. And part of precision treatments is treatments that people will follow. They've left out the caregivers. As a caregiver, I rule where my husband gets treatment. Because I've also become a snowbird, I work in 2 large healthcare systems, and I left one. And it wasn't about his care, it was how they interacted with me and failed to listen to me. Caregivers make the decisions. When Washington started going down this, and the question that came back from CMS was, well, how about patient choice if we offer this as a service for the caregivers and that isn't what they want? And so the state came to me, how do we answer that? And I said, you're in la-la land if you think they aren't already making those decisions. And what our model does is to check to see if they're able and safe to do it and make them appropriate. We have this la-la world. The only 2 places in the healthcare system where the family's actually engaged is in child care for children, because that's sort of required, and hospice. We engage. In between, these people are just seen as fluff, and they're driving the systems. We've got just a couple minutes left. Last question, anybody?
Are you in all 50 states?
No, we are working our way. We are a startup, we're working our way. We're actually in 17 states, some of them at the state level, some of them at an organizational level, depending on where we are. We have a couple of healthcare provider systems that are using it, but we're mostly looking at healthcare payers. We've figured out that that's really where it is. The dual eligibles is the real sweet point, because there's lots of savings to be had there, as well as the Medicare Advantage plans.
So you're really going in zip code by zip code, essentially, and pulling together services for the zip codes you're currently covering.
Yes, but they're usually in larger databases that already have those. The advantage is, as we grow and expand and get prettier, those zip codes will allow a lot of information about where services are absent, gaps. The organizations using them have already done that to some extent, but not in a strategic way. And we haven't been set, our newest, we are updating our UI, it'll be out on June 6th, and with that is coming a dashboard for the organizations to see many important things about their population. Yes?
So there's a stat earlier that was interesting. It said, I believe 80% of caregiving in the US is done by family.
Yes.
So is it a mis-stereotype or just a different view as to what caregiving is and where it occurs for the family, where we typically hear that, elderly people in the US are not cared for as such as they are in other countries where
That is
there's a nuclear unit.
That is a total myth.
And what, have you done any comparisons with other countries? Not necessarily on that stat alone,
Yeah.
but what works in other countries doesn't work? Are there similar issues they're
Well,
facing?
most of the, okay, first of all, in the Scandinavian countries, the European countries where they have, single payers, these things are built into their systems, so they're friendlier. I had a graduate student who did it from China, who did studies in China, and the issue of aging people plus the single child policy has put old people on the streets there. It's a big issue. In Japan, there is a tendency that they talk about of abandoning grandma, put her in the nursing home and never come back. The myth often goes back to the idea that in some old day, in some golden age, family caregivers did this. Just look at demographics and it doesn't make sense. People didn't live to be 90. You didn't have 3 generations. And if you do any of I've done some of the historical studies where they're reading, reading what people have written in the diaries they've kept. The other thing is grandma generally owned the land. So grandma wasn't living with them, they were living with grandma. So if you go back historically, this is sort of a historical false story. And actually, women, after we, became really one of the worst cases and the poorest people in this country, when grandma no longer owned the land and we don't have a system. We're done, I'm told. Thank you all.